So good morning, everyone. Welcome to this morning's session on culturally responsive and equitable evaluation methods and applications. My name is Jackie Jacobs, and I'm the Director of Evaluation at SUHI, and I oversee our evaluation and technical assistance strategy. SUHI has been leading evaluation development and implementation, as well as building evaluation capacity since its inception, and began to more formally offer evaluation consulting services in 2016. As you'll hear about during this presentation, our methods are really framed around centering the communities that we serve, while also including a level of rigor that will allow us to measure outcomes and impact. So today you will hear from myself and two of my colleagues, Benita McCarn and Cindy San Miguel, who are two of our evaluation program managers. Just to give you an overview of what we're going to talk about this morning, we'll start with a brief description of program evaluation and why it's important. I'll give you the framework and theory behind two evaluation frameworks we will focus on today, and then Benita and Cindy will each tell you about a project for which we have applied these frameworks. Finally, we'll leave you with some tips for applying these theories in your own work and provide some COVID-19 considerations. We'll also leave some time for questions and discussion at the end. So as Jacob said, please feel free to drop any of those questions in the chat and we'll address those at the end. So to start us off and make sure that everyone is on the same page, just laying that groundwork, I want to give a broad description of evaluation and the different types. So broadly, evaluation is a systematic process to judge merit, worth, or significance using a range of evidence and values. There are a few different types of evaluation, which each answer different types of questions and use slightly different types of data. Process evaluation answer the questions that assess the processes involved in your program or how it's been implemented. They also help you measure the outputs, the number of people served, the number of trainings conducted, the number of mental health screenings, really kind of those quantitative numbers that we think of. Outcome evaluations will answer questions about whether or not your program is meeting the goals that you've defined. They're typically measuring outcomes that speak to the change that you're trying to achieve. Percent increase in patients with managed diabetes, decrease in COVID-19 positivity. There are also economic evaluations that provide information on the relationship between costs and outcomes of programs such as cost utility, cost benefit, and cost effectiveness evaluations. And finally, impact evaluations, which go beyond the predefined outcomes that you've identified with your stakeholders. Impact evaluations allow you to explore both the intended and unintended impacts of a program. What are you seeing that you didn't expect? Evaluation has value for all stakeholders. People always ask this question, why? If you're part of an organization that is delivering a program, a clear evaluation plan developed early in the process, and I stress that early, can help to make sure that you're accomplishing what you intend to and will help identify opportunities for improvement. Evaluation really is not about documenting what went wrong just to document it. The point is to make change early for continuous quality improvement. For funders, it helps to gauge program impact and sustainability and will help you identify growing needs in the community, the value of a specific program, and use data to drive funding decisions. And for the community served, monitoring and evaluation ensures that programs are providing the best services to the people that need it most. The first framework that we're going to talk about today is equitable evaluation. The equitable evaluation framework seeks to redefine the role of the evaluator to make sure that the evaluator harnesses their power to progress equity and place the community in the center. Equitable evaluation is grounded in these three principles. First, evaluation work should be in service of and contribute to equity. Second, evaluation can and should answer critical questions about the impact of evaluation strategies on different populations and cultures and the underlying systemic drivers of inequity. And the third is that evaluative work should be designed and implemented in a way that is grounded in the underlying values of equity, such as using culturally competent methods and promoting participant ownership. The second framework that you'll hear about today is culturally responsive evaluation. Culturally responsive evaluation is a framework used to center evaluation in culture and historical context. It lifts up beliefs and values and integrates it into evaluation planning, implementation, and interpretation. Similar to equitable evaluation, done well, culturally responsive evaluation brings balance and equity to evaluation practices. There are 9 key steps in the culturally responsive evaluation framework. First, prepare the evaluation by becoming educated on the community and the context within which you're doing the evaluation. Step 2 is to engage a diverse group of stakeholders, inclusive of those who will be impacted by the program. So this can be your community, this can be funders, this can be other programs, policymakers. Step 3, identify the purpose of the evaluation. Who is calling for it and what is the program trying to accomplish? Step 4, frame your evaluation questions using stakeholder perspectives to define and prioritize those questions. Step 5, design the evaluation in a way that is appropriate for the community, including data collection tools and methods. Step 6, select and adapt instruments as appropriate considering culture and context. Step 7, collect data. Anyone involved in data collection should be trained in the instruments, as well as appropriate methods for administering them in the community. Step 8, analyze the data in a way that considers the nuances of the culture. Key stakeholders should be involved in order to capture meaning from the data that evaluators may not be aware of. And finally, step 9, share those results back with the community and your stakeholders. It's really important to close the loop and ensure the data is used for positive change. Typically, evaluation may be done completely in English, with the evaluators as the sole input for developing a framework. They're evaluating or doing research on the community, and evaluators interpret the data. They are the expert. But when considering culturally responsive and equitable evaluation methods, data collection is in the preferred language of the target population. Evaluators work with the community and with stakeholders to develop frameworks and questions. Stakeholders work with evaluators to interpret the data, and community members are positioned as the experts. So with that, I think that's enough of laying the groundwork. I want to pass it off to my colleagues who will tell you a little bit more about how we at SUHI have applied these frameworks. So I am going to pass it off to Benita, who will start us off with those case studies.
Thank you, Jackie. And thank you everyone for joining us today. It's great to see so many familiar names here. And I'm excited to share with you how we applied an equitable evaluation principles in our evaluation of a community health worker initiative. So first, some background. In 2017, Community Memorial Foundation and Healthy Communities Foundation collaborated to fund models of healthcare delivery that utilize community health workers, thus improving access to care and growing the workforce. This project was designed to address the expansion of equitably focused community health as the western suburbs continue to diversify, with families moving from the city of Chicago to the western suburbs. This migration presented opportunities to focus on culturally competent models. Health and Medicine Research Group is the convener of this project, and 5 organizations with diverse missions and target populations were funded to address the Regional Health and Human Services Agenda priority to create communities with accessible, high-quality health and human services for all. Specifically, the CHW pilot seeks to address the ongoing local need to increase awareness of health and human service resources and connect people to needed services. As part of this initiative, CHWs and supervisors participate in a learning collaborative to engage with one another and content experts to strengthen their skills, referral networks, and knowledge. SUHI has dual roles as trainers and facilitating the evaluation. I'm the lead evaluator of this initiative, documenting the evidence base and providing the framework for telling a comprehensive story of this project. It's an enormous undertaking since we have 5 diverse organizations within this pilot. There are many components to this project as a whole, but today we'll focus on the evaluation of this initiative and how we approached it with an equitable lens. Our project encompasses the areas outlined here in green in the western suburbs of Chicago and Cook County, serving 18 clients in 18 community areas with a population of over 171,000 and encompassing 42 square miles. So I want to break down the steps that we took to apply equitable evaluation principles to this pilot initiative. In step one, in brainstorming our approaches, we approach this in a spirit of collaboration. In step two, as Jackie mentioned previously, equitable evaluation works closely with stakeholders at all levels to identify evaluation questions and frameworks. A unique aspect of this project is that it's a true collaboration with community health workers, supervisors, learning collaborative trainers, and project conveners from Health and Medicine Policy Research Group and the funders each step of the way. For example, the community health workers were vital to the process of creating data collection tools that would answer our overarching evaluation questions. I'll cover these questions in more depth a little bit later on. And step three, responding to feedback. As we rolled out some of these data collection tools, I learned from our CHWs that there were gaps in the data that they were collecting. So I created an additional tool to address their feedback. In step four, providing technical assistance. An important component when rolling out new data collection tools is training, so technical assistance is built into the process. In step five, refining the process, continuing to monitor and build on what is working well and addressing aspects that are not working so well. And finally, step six, continuous project improvements. This step has been really integral. In year two of our project, stay-at-home orders due to COVID-19 meant that many of our CHWs who had been working out in the field in direct contact with clients pivoted to working with clients in a virtual environment. However, some of our CHWs remained in the field. These shifts provided opportunities to continually improve our project and the associated data that we collected to measure the effectiveness. So now I want to move into talking about what we decided as a group to measure and evaluate. Equitable evaluation means that we work collaboratively to create our measures of success and develop our evaluation questions. Remember, the goal of this project is to improve access to care and advance health equity for individuals living in the western suburbs of Cook County. As a group, we determined that we wanted to know how organizations are developing visibility and working in partnership with local agencies. How are CHWs engaging with clients in the target area? The Learning Collaborative is a substantial component, so we wanted to know how engaged are CHWs in the Learning Collaborative and how have their skills increased as a result of their involvement in the Learning Collaborative. In the first year, with vital input from CHWs and supervisors, we created a data collection tool to track the project-wide indicators and referrals. So over here on the right side of the screen, you can see our data collection tool. This data collection tool collects quantitative data, while we also are incorporating qualitative data collection via interviews with community stakeholders, CHWs, and clients in year 3 of the project. The evaluation objectives of each project year are intended to build upon the work and learnings from the previous year, culminating in a mixed methods approach of compiling lessons learned, documenting the contributions of CHWs to their organizations and to participants' health and well-being, and identifying best practices for sustainability. In year 1, we discovered the challenges organizations face to determine the outcome of a referral. These challenges included the lack of an integrated system for tracking what happens after a referral is made, and in many cases, confidentiality compliance. In the second year, we incorporated the use of the Hub, a widely used social care network designed for collaboration with community-based organizations. With this integration, we found that organizations were able to connect directly with referral locations for a warm handoff and more easily track if a client received the services they needed. As a result, referrals resulting in clients accessing the services increased from 26% in the first year to 71% in the second year. So I want to just comment on this, that the increase may be due to better tracking and documentation. We don't think that the only 26% of clients receive services in the first year, but we figured out a way to more accurately track and to close the loop on the referrals. So as this is a true collaboration, communications department from Community Memorial Foundation and Healthy Cities Foundation created a one-pager with a snapshot of the key outcomes from year 2. So part of that one-pager is what you were seeing in that previous slide. So I want to wrap up with how we incorporated equitable evaluation principles, the lessons learned, and best practices. We incorporated equitable evaluation principles with co-crafted and co-developed tools, which I mentioned previously with our data collection tools. It was a true collaboration with shared leadership and vision for the project as a whole. We also shared learning and insights. This inclusive approach provides a holistic lens in understanding the context of the outcomes. What I mean by that is that data is reviewed by our CHWs and supervisors, and that perspective is woven into the analyses so that we can address any biases that can be in the evaluation. So going back to that chart that Jackie shared earlier, in traditional evaluation, evaluators are seen as the quote unquote experts. We needed the expertise and perspective from several angles. For example, the first year demonstrated the creation of a large referral network, but we saw an opportunity to close the loop on referrals. It's not really clear what happens with a client after a referral is made, if a person received the services they needed. So we worked together to create a more dynamic and robust system for closing the loop. This kind of approach needs a lot of intentionality with time built into the timeline for data review by all stakeholders to understand the context. And finally, in terms of best practice, providing space for all organizations to see, interpret, and provide feedback on project metrics that are shared is really important. Making room for continued adjustments with flexibility and nimbleness, incorporating the lessons learned, and being open to incorporating temporary adjustments into permanent workflows. This really became a key component of this last year when we found that alternative ways to outreach during COVID-19 became permanent workflows in some of our different organizations. And now I'm going to turn things over to Cindy San Miguel, who's going to talk about culturally responsive evaluation.
Thank you, Benita. Hi, everyone. My name is Cindy San Miguel, and I will be talking to you about our work on the Health First Collaborative and our utilization of a culturally responsive evaluation model. I just want to acknowledge that I've been working on this project with two of my colleagues, Jackie Jacobs, who is facilitating this panel, and also Amanda Peters, who is a research specialist on the evaluation and technical assistance strategy. Their brilliant minds and collaborative spirit have really helped move this project forward. So I want to get us started with just a brief history on how this project got started. So the project was kicked off fairly recently in the summer of 2020 in light of the public murder of George Floyd and the community's response to this tragedy. Several Chicago-based foundations decided to pool their resources to have a collective impact on the twin pandemic of COVID-19 and the historical racial injustices that have plagued the Chicagoland area. And so the purpose of the Health First Collaborative, or I'll use the acronym HFC throughout this presentation, is to address the root causes of health inequities and to improve the physical, mental, social well-being of individuals and families in the Chicagoland area. The Health First Collaborative aims to support demonstration pilots that can be replicated and/or scaled. The first cohort of demonstration pilots focused on community health centers as hubs of health transformation. This was an intentional step because of the integral role health centers play in the community and because of their role as first responders in the pandemic. In addition, the health centers selected for the first cohort were identified because they serve Black, Latinx, and uninsured population. So this slide shows you an overview of the HFC. As you can see, there's a lot of components feeding into this project. And so on that top right-hand corner, as mentioned, you have the health transformation hubs. The hubs for this first cohort, as mentioned, were community health centers. And they include the following: Esperanza Health Center. This is an FQHC with the flagship site in Brighton Park and various locations on the southwest side. We have Community Health, a free and charitable clinic that serves only uninsured populations. And they mostly have been in the area of Westtown, but started a microsite in the community area of Belmont Cragen. Then you have the Southside Population Health Collaborative. So this is a collaborative of 5 federally qualified health centers throughout the Southside of Chicago, and they serve communities that are predominantly Black or African American. The 5 FQHCs that are part of this collaborative are Christian Community Health Center, Chicago Family Health Center, Beloved Community Family Wellness Center, Family Christian Health Center, and TCA Health. So Esperanza's project focuses on the utilization of telehealth to enhance behavioral health services. Community Health Project, as I began to explain, focuses on the creation of a microsite where they will provide hybrid telehealth visits with the support of a medical assistant inside a community-based organization, Onward House, within Belmont Cragen. And the Southside PHC, Population Health Collaborative, is working to creating a shared health IT platform to better coordinate care across their patient population, particularly as it's related to accessing specialty care. SUHI's role is to oversee the evaluation of the entire Health First Collaborative. In addition, we've congregated the pilot sites in a learning collaborative where they can share insights and lessons learned as they roll out their pilot projects. We've also convened community advisory councils to help inform the evaluation and advise the Health First Collaborative. We've been collaborating with the Shriver Center on Poverty and Law to identify areas where policy change is warranted. So those are the components that feed into the model. So this is the slide that Jackie previously shared on the framework for culturally responsive evaluation. She detailed the various steps that are involved in this framework, and I'm going to focus on the first 7 because that's the progression we've made thus far with the project. And the next several slides will detail how we've worked in those steps. So step number 1, preparing for the evaluation. As you heard in the first portion of today's events, and as you'll hear throughout the day, SUHI has a long-standing history of examining and understanding hyper-local health inequities that exist throughout our city. So that's where we started, and just thinking about what do we know about the communities that are involved within this project. From there, step 2 and 3, we engaged with the stakeholders and identified the purpose of the evaluation. And so for us, the stakeholders were the funders, the pilot sites, and community residents that live within the community areas that have most been impacted by COVID-19 and racial injustice. And we've conducted focus groups with all of these various stakeholders. In addition, as mentioned, we convened 2 community advisory councils. We convened 1 English-speaking council and 1 Spanish-speaking council to be able to allow Spanish-speaking residents to participate in the language that they feel most comfortable speaking. This map that you see represents all of the community areas where community residents come from. So you can see that folks are coming from all over the city, but there is a higher concentration on the south and the west side. And that's where we see some of the communities that have been most disinvested and oppressed in the history of our city. All right, so step 4 and 5, we have to frame the right question and we have to design the evaluation. So we've continuously discussed the evaluation in the Learning Collaborative and with funders. We've had a very high touch relationship with the funders to ensure that we are incorporating what they foresee that the direction of the Health First Collaborative. In addition, ensuring that we understand what pilot sites think the impact will be and what are the most important indicators and outcomes that we should be tracking as part of the evaluation to understand impact. In addition, we've conducted various activities with the Community Advisory Council to understand their definitions of health and well-being based on their lived experiences within the community and incorporated those indicators into the evaluation. Steps 6 and 7, select and adapt instrumentation and collect the data. And so as you can imagine, and as I mentioned, there's a lot of different pilot sites, and some of the projects that I described might seem very unique and the overlap might not be as obvious upon first examination. So we've done a lot of work and have had constant communication with the pilot sites to think about, what's the collective impact? How do we standardize collection of data across, the 8 different health centers that are involved in this project. So, think of something like patient satisfaction, where community health center A might be asking the question in such a way, and health center B might be asking the question in a different way. And our role is to try to think about, is there a way that we could ask this question in the same way so that we can really understand collective impact? All right, so this slide shows you a preliminary theory of change. And so this is showing you the activities, the outputs, the outcomes, and the overall impact of the Health First Collaborative. And so in activities, we have, that what we have represented is everything that's happening with the pilot sites, our learning collaborative, the policy work, and the community advisory councils. And I don't want to I hope we don't minimize the work of the pilot sites, because that little box represents a ginormous scope of work. I mean, these folks have been working tirelessly over the last several months, and from hiring new staff to adjusting workflows to designing spaces within community-based organizations to creating BAAs with different specialists that work in various hospitals. So there's a lot of work that's happening there. So I just want to make sure that I call out their work. And so we have tied those activities to outputs, process measures, population health data, programmatic measures, community engagement measures, and policy measures. And then we're tying those to outcomes. So we want to understand what's the quality of the healthcare experience. We want to deepen community engagement. We want to understand how this is impacting an integrated service delivery system. We want to track health outcomes for the target populations of this project with the Black, Latinx, and uninsured individuals. We also want to ensure that we're thinking through sustained models. Is this a sustainable model of care, and where's the innovation? We tied these health outcomes to the 5 pillars that were established with the Health First Collaborative: racial equity, cross-sector engagement, coordinated and integrated care, policy and advocacy, and systems change. And all of this is with the effort of eliminating health inequities by decreasing the life expectancy gap. All right, so lessons learned. I promise there's a reason why I chose this picture, beyond that I thought it was really pretty. As I was thinking about the lessons learned, I thought about a kaleidoscope. Now, if you remember being a kid, and if you ever had the chance to play with a kaleidoscope, you look in through this tube, and as you kind of twist the tube around, the colors and the patterns within that tube change. And that's really what that was the best visual representation of what I could think with the lessons learned. So the first point: conducting a multi-site evaluation with unique projects requires buy-in. Everyone has to agree that there's some type of pattern, there's some type of overarching, unifying, end goal that we're working towards. And so, we have buy-in from the pilot sites, from the funders, and from our community. In addition, it's critical to represent the diversity of Chicagoland communities, but it doesn't come without its challenges. So, in the same picture, you see a lot of different colors, a lot of different textures, and I think that's true of Chicagoland as well. We're a very diverse city, and we, really thought this through. What are the voices that need to be represented here? How do we recruit them all? What's the model that we go with? And so, we made that decision, and it worked within our capacity to have 2 different councils. But then we got into some more complicated questions of, do we need to have a youth council? What about other languages? Do we have the right representation of communities? And so, and we have to kind of weigh that all out with our capacities. So we did make some connections with the MICBA Youth Council, and we do have some of their some youth representatives on our community advisory councils, which is great. And then adaptability. I mean, I think we heard this with Benita's presentation as well, but this has been an absolutely necessary component with this project. I think right when we think we understand what's happening with the pandemic and what's happening in our city, the kaleidoscope moves again, and the pieces are moved around. So, we were thinking about the first surge and how health centers were concentrating their work and energies around that. And then there was a second surge, and then now we're rolling out the vaccine. So priorities have shifted around. And so we've just been very cognizant to make space to acknowledge how the work is changing and understand that priorities are competing, and what is that toll that it takes on the health centers that are part of this project. In addition, we've taken that same approach as we're working with community. What's happening in the community? What do we need to acknowledge as we're working through this space? You can think about like even a day like today where we know what's happening in the context of our city. To just push through with our own agenda would be inappropriate. So we're always just thinking about how do we stay mindful of the communities that we're working with? How do we ensure that we are paying attention to that as well? So impact. When I was thinking about impact, I think that a lot of the impact that's happened around Health First Collaborative has just an increase of webbing and an increase of connectivity. So we have, shared learnings between the pilot sites and the Learning Collaborative. We have increased engagement with community residents through the community advisory councils, and we're leveraging that CAC for rapid quality improvement for particular pieces and activities around the pilot sites. I mentioned that we've had a high touch relationship with funders, and that has only enhanced our capacity to be adaptable and to be nimble. And so we appreciate them also kind of accepting that nimbleness that we need in order to respond to this ever-changing project. And we recognize that the work isn't done, right? We're continuously exploring new mechanisms to engage with the community and thinking about, what's next? How else can the community be engaged? How else can we continue to be responsive to what's being presented to us? So with that, I'm going to pass it back to Jackie.
Great, thank you all. So you've heard about some ways that we at SUHI have applied these frameworks. So now it's time for you to get started. How do you do that? If you're a funder, consider asking your grantees to incorporate elements of these frameworks in their proposals. Also, be aware that this can take more time, resources, and cost more money. If you are a researcher or practitioner, be intentional and thoughtful about why you are applying these frameworks and how you'll do it. Consider how to apply these frameworks without overburdening the community. Be inclusive and support community engagement. Build in the time and be clear about your time frame. Ensure your budget can support the extra effort. It takes more staff time, more community support, and be clear about what can change and what cannot change. I think that's one of our key lessons learned as well, is there are some things that are built within a project, either determined by the funder or the intent of the program evaluation, that can't be changed. And it's really important when using feedback to help from the community to help drive this work, that you're clear about what can and cannot be changed. And finally, be aware of the power dynamics. If you're a student, learn as much as you can, read articles, try to apply them in your schoolwork, and find opportunities to join in on projects that leverage these approaches. If you're a community resident, be open and honest about your feedback. The evaluation team is counting on you for your input. Request clear expectations and roles. You have power and agency. Be thoughtful about how to use that. And finally, think about what is a good use of your time and what the return on investment is for you. It's okay to push the evaluation team to demonstrate the value. And now that we've been doing Zoom meetings for over a year now, I do think that it's worth taking a minute or two to talk about some COVID considerations. First, support equitable participation on virtual platforms. Not everyone is Zoom, WebEx, GoToMeeting literate, or even comfortable with it. Give stakeholders space to practice how to log in. Provide equipment to support engagement, such as providing tablets or computers with webcams, or even internet hotspots or stipends. Be aware of how different virtual feels. Normally, we'd all be in person today. You would get some casual in-between session conversations and maybe even some free coffee and snacks. In this virtual space, people are really missing out on that key relationship building. So think about other opportunities for how to build that into the work that you're doing. Be sensitive to personal issues that arise. Although we're doing really important work to demonstrate the impact of programs in our community, recognize that people at an individual level are really struggling right now. Identify some disaster management techniques. If it's not COVID, it might be something else. And finally, recognize that people are being impacted differently. Some people have lost their jobs during this period, while others have seen an increased demand and burnout. Some have experienced loss, while others have had to take on caregiving responsibilities. Everyone has their own experience and own truth. Thank you so much. I hope that everyone enjoyed and has some good questions for us. So I will now hand this over to Amanda, who I think is going to facilitate some questions.
Thank you for unmuting me, host, and thank you, Jackie. It looks like we have some questions that have been both sent privately to me as well as shared within the chat. So I'm going to start off with this first question. How did you build capacity within communities who have no experience with evaluation so they can participate to the highest degree possible?
Yeah, I mean, I can get us started. I think that it's framing evaluation in a way that makes sense to people. So, ensuring that we're using the right terms. I think using language of like we know what are the things that affect our community, and really kind of centering what's their expertise through their lived experiences. So um, being very intentional with that, of saying we've asked you, we've recruited you to be part of this process because you have something um, that us as evaluators, in this different role, we won't be able, we won't be able to contribute in that way. And so I think centering their role as experts and saying, you can tell us something about how we understand how this project is going to, roll out in your community more than we can. And, I think I hear that question in that, sometimes the technical terms aren't there, but people have a lot to say, let me tell you. And I love that about our CACs, our community groups, that they feel like, we've been here already knowing what needs to happen, and we're just waiting for y'all to show up and like be in the space that we are. So we haven't necessarily, I guess, in our project seen that kind of like, well, that unsureness. It's more of an eagerness to want to respond. And, with that question in our next meeting, which is actually in a week, we are going to be kind of doing an overview and probably pulling a lot of pieces from this presentation to share with the CAC to say, this is how based on your feedback, this is how we've incorporated it into like a theory of change model. Like this is how we're seeing it be an input through, how we've identified these outcomes. So that's been my experience thus far with the Health First Collaborative.
I will also just add to that I think it's been really important to provide some baseline education around evaluation, that we shouldn't assume that everyone knows what it is. Some of the frameworks that we presented at the beginning of this presentation can be really helpful. We've had members who are helping to guide our evaluation specifically ask for things like that, and being able to provide them with a little bit of more didactic education about what is evaluation, why is it important, and what is it that we're going to be doing can help them understand how to frame their input in a way that's most effective.
Thank you. I'm going to go ahead and move to another question that we did receive in our chat box earlier. It's regarding data collection. Is the platform that you all used compatible with patient EMR data? Also, they noted that you collected social determinants of health indicators. Did you also use Z codes for EMH and reimbursement purposes? And if you have any questions about the acronyms that were used or any follow-up questions for the person that posed that, I can go ahead and collect that in the chat.
Thank you. I'll take that question. I think that was related to our evaluation of the CHW initiative. So the interesting thing about this project is that the organizations were very diverse who participated. We only had one of the organizations was a clinical organization who had access to an EHR. And so the data collection tool wasn't really combined with EHR data at all, or Z codes. But we're working towards ways that some of the CHW work will be reimbursed at some point. And as you know, some of the legislation is changing around that. And so we're keeping on top of it and ways that we can make this project sustainable going forward after our funding period ends. But our data collection tool was basically a spreadsheet that that the supervisors collected the data from the CHWs on the number of contacts, the referrals, the type of referrals, things like housing, food insecurity, medical assistance, and things like that. So, so to answer your question, it wasn't compatible with the EHR system.
Thank you, Benita. Alrighty, I have another question. This is regarding the Health First Fund project. How may this project affect policy and advocacy efforts?
Yeah, that's a great question. We were doing another check-in on that this morning. Yeah, so I think one of the key policy areas that we've been monitoring have been policies around telehealth. So as some of you may know, there have been some kind of emergency stipulations around reimbursement for telehealth visits in the COVID environment. And so, we didn't have an opportunity to dive too deep into the pilot site work, but what we're hearing from the pilot sites is that they're using this as an opportunity to really test this out. Like, what would it look like if we could operationalize telehealth and maximize its utilization and our healthcare delivery to increase access. And so we're seeing a number of pilot sites, try to test this out and say we're being reimbursed right now. CMS is allowing us to do that, and let's see what it would look like to change our workflows to increase our capacity, to expand our reach. But that all works right now because we have that reimbursement, right? Because some of those stipulations have been made. And we don't know when those policies will be changed again. There is some work right now in the Illinois legislature to see what it would look like to continue reimbursement. So that I would say would, and when I'm saying reimbursement, it's mostly around Medicaid. And so that's what we're following and we're tracking to see, is there anything in terms of the evaluation, in terms of data collection or stories that we can ensure that we're capturing to support some of those policy pieces that would increase access to healthcare. So that's one example. Jackie, is there anything else you want to add?
I think the only thing I was going to say is that policy and advocacy, to one of the points that I mentioned earlier about building in evaluation from the beginning, it really is the same for policy and advocacy. And the idea was, we don't know exactly what the evaluation outcomes are around policy and advocacy, but we know that to create, real sustainable change, that needed to be included. So part of our developmental and participatory approaches to building out these frameworks was to think about what are the key needs right now related to policy. Telemedicine has been one of them. And then the other that we're speaking about is this access to internet and digital divide, and making sure that internet and technology is equitable.
Fantastic. I'm going to go to this question here because it is specifically for Benita, so I think it's related to that project again. Is the referral data still being collected through that spreadsheet, or has the group evolved to a different method of tracking the referral data?
So it's being collected in two different ways. So it is being collected through that spreadsheet that I showed earlier, but we're also collecting the data through the hub that I had mentioned as well. And so with that, we can see what happens with a referral. It can track a referral all the way from the point that the referral is made to what happens with the client, and then basically close that loop that we talked about that we were having a really hard time closing. And so we have had a lot of evolution in this project, and we continue to be flexible and nimble in how we approach things. Another thing is that our data collection tool had some limitations in it, in that we limited some fields based on the number of contacts just for data collection validation. And we found that in the virtual environment, people were reaching out to they had a lot more contacts than we had anticipated, and that they had in pre-COVID times. And so we needed to change some of that validation to account for the increased contacts that CHWs had with clients.
Thanks, Benita. Our next question also was sent in the chat, and I think it's an important question to ask. What have been some of the greatest pain points with funders? And being mindful that we may have some funders in the room, so I think this is a great question to pose.
I think this is good. I'm all for, let's call out the elephant in the room and ask these important questions, because that's the only way we'll be able to learn and move forward. I think that I will say, not just because we have funders that are a part of this conference, but for these two projects, the funders, there really haven't been any painful issues, because I think they buy into this. You need funders that really buy into this model. We certainly have had other problems and relationships where some of the issues have been that There's there's limitations on funding. There are, it may be a nice idea to involve the community, but we can't spend $8,000 supporting that effort. And, that's just an understanding. I think the things that have been very successful and allowed us to use these methods with building relationships with these funders is open communication, having regular check-ins, being comfortable sending an email and saying, you know what, this method isn't working. We may need to try something else. How do you feel about that? Should we work together? So really not this hierarchy of funder and grantee, but let's work together if that's something that the funder is interested in doing. And I think a lot of these projects have given us the opportunity to be thought partners and put our expertise and our brains together to figure that out. I think also a lot of these relationships and the work of the evaluator is sometimes to dig into what is it that we're trying to achieve. So I think it was some of those earlier steps in the culturally responsive methods framework, which is, what are our evaluation questions? What are we trying to answer? And getting input from everyone, and really having, I'll say funders because that was the question, is what is your organization? What is your foundation? What is, if it's a government entity, what is it that you're trying to achieve? What is your goal? And how can we work together to fit that in? And sometimes it's really iterative. And the evaluators say, okay, we hear that you want to achieve X. And they're like, not really. So we try again. And so it's just working together, being honest and going back and forth so that you can really do the work that's best for your target population.
I do want to add something that I think has been interesting. So as Jackie mentioned, I think the funders approached us, this collaborative of funders approached us and said, we want to kind of break beyond the traditional relationships that funders have with fundees and allow for some vulnerability, right? Allow for some mistakes to happen. And, if we're testing things that haven't been done, right? Like, as mentioned, like this telehealth model is new, this shared IT platform is new. And so we don't really know what's going to happen. And I think that a lot of when you're on the fundee, even from ourselves, you're used to saying, like, you want to be successful, right? You only want to show your best side when engaging with funders. But I think that asking for this increased vulnerability and open and honest communication has worked to our benefit. But it has been kind of a moment of growth, right? Because these are not relationships that are contained within a bubble, right? So you might be funded through other projects with the funders. So you're behaving, or like, that this project is with its kind of innovative goal, and you're testing something new. You're being asked to kind of, behave and present yourself in a different way than maybe you're comfortable with or used to. So I do think that maybe that was a moment of growth, but I think it's been to the benefit of the project, right? Where we have been able to just have really open, honest, transparent conversations around what's working, what's not working, how can we modify, components of the project or meetings to just best meet everybody's expectations.
I just have a small thing that I want to add to this. And I think that this really speaks to our equitability and our collaboration, that we have our funders here with us supporting this day, supporting our work in this virtual environment, but that they've joined us today as well. So that really speaks to our relationships with them.
Very much agreed. I'm going to actually go to this question that was just posed in the chat. And I think that we mentioned the CHW project here, but I think the question applies to all the projects mentioned, which is that Benita had mentioned increased virtual contacts between community members and CHWs during COVID. Is this something that will be incorporated into future programming, such as making clients continue to have that virtual access to assistance? What would that look like across stakeholders?
All right, I'll start with this one. And absolutely, we saw that one of the opportunities to really shift these workflows in some of our organizations was that it increased service lines for some of our CHWs and supervisors and organizations that they partner with. And in one of our organizations, the CHWs really work with an aging population, and they really stopped their programming over the winter months because they found that it was really difficult for their clients to participate during the cold season. And threats of things like falling was increased. But in this virtual environment, they were able to increase their the things that they offered, the programs that they offered, and this will be a permanent change in their workflow then. And so we have seen these shifts and modalities that these temporary solutions are becoming permanent parts of the workflow. But on the flip side of that, we've also seen this increase in that digital divide that Jackie talked about or mentioned earlier. And that's a really unfortunate thing that some of the clients don't have access to things like smartphones. They don't have access to tablets. They're not able to connect virtually. And so some of our organizations saw that clients who they had seen regularly in pre-COVID times, they haven't seen it all in this virtual environment.
Jackie or Cindy, anything else you would add?
Yeah, I mean, I think that you know, the engagement of community members in these projects is something that we're just seeing an increase overall across a variety of SUHI projects. And so, you know, I think I'm really proud of the strides that we've made to just develop best practices around engaging community in a virtual space. I think we've really made a lot of progress, and we're doing it right, even though sometimes it's more work. I think that we've been successful in those efforts. I think what that looks like once people start engaging in person or in post-COVID, I think some of that we're still kind of figuring out to seeing like what that'll look like. I do think that in general we're establishing like the norm is to always respond to whatever needs community residents need to participate, from accessibility to language to anything else. But yeah, I think some of that, maybe I'm misinterpreting the question, but that's where my brain is as we're thinking about going in, what meetings and engagement will look like in the future. I think accessibility in terms of virtual access will always be something we'll think about. But I don't know if we've necessarily like pinned down how those meetings will look like.
Yeah. I think you brought up a really good point, Cindy, too, that while we're keeping those things mindful, we're also mindful that those things may evolve. I mean, we're going to be returning to in-person format eventually in the future, and we have done that in the past, but it is going to look a bit differently than it did pre-COVID. So I think keeping that mindset is key. We also have a few more questions to post. I want to tell the audience that we do have about 10 more minutes for a Q&A. If anyone has at least a couple more questions that they have on the tip of their tongue, please feel free to put it in the chat. Moving on to the next question though. What is most uncomfortable to you all as evaluators, especially about using these methods? What is really hard about it?
Mm-hmm. That's a great question. I think one of the really difficult things is being seen as the expert, because we're not. I mean, we want to measure things, but we also want to include these other perspectives and these other voices, because we know that that makes the evaluation so much stronger, and it also provides more context for what we're the findings that we share.
I will say, I think that, I don't know that this is the hardest. I think it's something hard, but something that SUHI has been doing really well, which is you really need to build trust. And I think that it can be really challenging to build trust, have partners across sectors, including the community, who buy into what it is that you're doing and trust enough to join the team.
Yeah, I think along those lines, what makes me the most uncomfortable is just, I think I'm, like my colleagues and other folks at SUHI, just hyper aware of like the context that the work is having. We know that particularly in this project, when we're working with health centers, these folks are working so hard across so many fronts to respond to all the different fronts of the pandemic, right? From testing to vaccination to dealing with more complex social issues around unemployment and housing. So it feels like they are already overburdened, right? And so here we come, the evaluator saying like, right? Like this is so important, and we want to make sure that we capture that impact, right? And it involves trust and these good relationships. But I think it's so important to balance the burden of collecting data and ensuring that we have good data to capture and understand the outcomes and the impact, versus folks that are already like have a lot on their plate. So we are hypersensitive to that, and so we do a lot of work on the back end to try to minimize the burden on our partners, and think about what's the easiest way that we can collect this data. And maybe sometimes also just being flexible, being like, maybe the data we get won't be perfect, but there's a balance between not putting too much on the plate of a partner that's already doing a lot to support the infrastructure, but also ensuring that they get the credit. I feel like the evaluation is like, you're getting credit for all that work. It's so that others understand and see how all of this great investment of work, time, money, people capital is all leading to these like really great outcomes and impacts for your community.
I do want to lift up that point that Cindy just said about we as evaluators and data-driven people, we want to collect everything and we want it to all be perfect. And that's not the case. And that is uncomfortable. I think that makes me uncomfortable. It makes a lot of people uncomfortable, that you do need to kind of weigh those pros and cons, weigh the burden, and you need to be selective about it. So I think that's a good one.
Thank you. I also have another question that was shared with me privately. Equitable evaluation seems like it shares a lot of the same tenets as empowerment evaluation. Are there any key differences?
That's a great question. I haven't considered the how they differ really a lot.
I always think of equitable evaluation as, and this just may be the way that I've applied these, is I think of equitable evaluation is a little more rooted in kind of context in history, and empowerment more on the individual level. And I think the way you apply them and the methods are probably very similar. About equitable evaluation is about empowering the community. Like using those methods does empower your target community, those who are involved in the evaluation, who are not necessarily the evaluators. So I think the outcome is the same. I always think of it as kind of the root cause and the reason that is driving that framework as being a little bit different.
Great. It looks like here that I might have my very final question. Alrighty, so I had listed in here at least what have been the biggest challenges you've encountered in these processes and projects highlighted here, but I know we've talked a lot about challenges. What are some of the positive highlights that you can all share with us? Some of the testimonials, especially from community members.
I can share since my project's just a little bit farther along. And I would say sharing the results and sharing some of the findings with our funders and with our community health workers and our supervisors is always a defining moment. And it's something that having that responsibility to be able to tell this comprehensive, holistic story is really, it's so gratifying and so satisfying. And so when people can see their work and the collective impact of their work, I think is really, really powerful. I've had that joy this week when I shared some of the results from our year 2 project with our community health workers and supervisors. And that moment where people can see their individual work, the collective impact that it has across the year, that they can see the one contact that they had on this one day and the way that it all comes together to tell a really cohesive story of their work is a really defining moment of evaluation.
Yeah, our project is not as far along as Benita's, the Health First Collaborative, and so. But I do think that some of the successes are more around just building that webbing. And so like in our learning collaborative, one of the yes moments that I had was in one of our learning collaboratives, we had community health do a presentation on like their communication strategy. And, you know, folks, other health centers are like, wow, show me this video, show me how you did this, and how did you build up this YouTube thing, and tell me more about the strategy. And Esperanza chimes in and like, look at this cool texting app that we have going on. And to so see that just like very organic moment where folks are sharing their methods, what they were utilizing to enhance communication was just like, was really great to witness, to see that just increased capacity, and you know, saying maybe not something we'll try today, but now we know more about that and we want to consider what that would look like at our own health center. And we've seen similar moments with the community advisory councils as well, of just like building that shared understanding of what's happening across all of our communities throughout the city, so that, you know, I think at times COVID has felt just really personal and isolating. So to be able to bring people together across the city to share their experiences, and you know, have them feel that their voices matter, that they can contribute ideas and thoughts around what the response should look like, I think has been really, really great to just, and humbling to like sit in that space.
The only thing that I'll add to that, I agree, and I don't need to belabor it, but I think for all of these projects and others where we've used these methods, for me, the most exciting thing is learning from other people and thinking about things in a way that I would not have thought. And I think the experience from our stakeholders and the lived experience from community members really change my perspective. And I've made decisions that are different because of that.
Thank you. And it looks like we have the most perfect timing ever because it is towards the end. Before I hand it over back to Jacob, thank you so much to Jackie, Benita, and Cindy for answering all of these questions. I think that was a lovely note to end on. And Jacob, I'll pass it off to you for what's next.